Good morning, everyone. It's my great pleasure to introduce our today's speaker, Dr. David Mauchley. And I will be honest, we just met via Zoom, but he was recommended by me by a dear friend of mine who is a pediatric cardiac surgeon at the University of Washington Medical Center. And I was trying to get him here to speak to us. And he said, "You really don't want me to speak about big people, but I have a guy for you who's amazing." And he suggested David. So David graduated from medical school at the University of Washington and then did a lot of postgraduate training at the University of Colorado, including general surgery, thoracic surgery, and then congenital cardiac surgery. His first job was at the University of Alabama in Birmingham. And again, David does not know that, but that's where my American experience started. I did 6 months of medical school at UAB, and I'm not going to share when. And then in February of 2020, he moved back to University of Washington Medical Center and is actually working in both pediatric and adult congenital patients and is involved with cardiac transplantation and also mechanical circulatory support for patients with congenital heart disease. Today, he will be speaking about new approach to the surgical management of adults with congenital heart disease. So we're really excited to have you here today. And I also want to mention it's 5 a.m. in Seattle. But I said to him, he's a surgeon, so it's kind of like our 8 a.m. So I think we're good. I also would like to acknowledge our sponsors today. Very much appreciated. Thank you.
All right, well, good morning, and thank you for the invitation. I had a really good time putting this talk together because the surgical management of adults with congenital heart disease is something I've been passionate about since really early in my career. And I do think it's a population that gets overlooked a little bit, and we have a really good program here in Seattle that I'd like to tell you about. Specifically, my partnership with one of the aortic surgeons at the University of Washington, and how that partnership has really, blossomed into an excellent program. Let's see. Sorry. No, it's not advancing. There we go. So I don't have any disclosures other than an interest in adult congenital heart disease since an early time in my training. And I will just elaborate a little bit on my training. I did all of my surgical training, as Katya mentioned, in Denver, Colorado. And when I was an adult cardiac surgery fellow, every once in a while we would have these congenital patients that the congenital surgeons would come over from the Children's Hospital to help us with. And at the time we were a little bit short on fellows and we didn't have a lot of time to go to the Children's Hospital. So this was really my only exposure to congenital heart disease until my last year of adult training. And I always thought the cases were very interesting, mainly because there was so much reconstruction involved in the cases, certainly more so than typical coronary bypass or aortic valve replacement. And the patients, I would say the patients were different. They were a little more grateful in terms of the fact that they had already had many operations in the past. And that's where my interest peaked in this population. So to start out, I'll just give a little bit of background, and many of this is fairly well known to anybody who works in the congenital world, but in the last 80 years, there have been really amazing advances in the care of patients with congenital heart disease, going all the way back to the Blalock Taussig shunt, moving up to the development of the cardiopulmonary bypass machine, the Fontan operation for tricuspid atresia, and then the 3-stage palliation for patients with hypoplastic left heart syndrome. That, along with the improving surgical techniques, there's been an improvement in ICU and anesthetic care, as well as transcatheter interventions that have allowed patients to survive to adulthood much more frequently. If you look back to the 1940s, it was very rare for an adult or for a child with congenital heart disease to survive to adulthood, but now it's really the expectation. More than 90% of our patients that we operate here at Children's, we would expect to make it to adulthood. And if you look at the explosion of adult patients in this population, the graph here on the right of this slide is from Canadian data, where they actually do a really good job of keeping track of their patients and have an easy medical record to follow. They showed that by 2010, about 2/3 of patients with congenital heart disease in Quebec were adults, with 1/3 of them being children. And that a similar ratio occurred even if you looked at the patients in terms of their complexity of their disease, where patients with single ventricle disease, transposition of the great arteries, some of the more complex anatomies, the 2/3, 1/3 ratio really stuck. And so now I would say that there's well more than double, now that we're in the 2020s, in terms of patients with that are adults with congenital heart disease compared to kids. And they just keep getting more and more complex as we're allowed to, or as we or as they are living into adulthood more frequently. So what does that look like in the United States? Well, our ability to maintain medical records is not as sophisticated as the Canadians. So the Canadian group that published the paper I just showed you actually took their methods and did and applied it to the American population to estimate the number of adults with congenital heart disease in the United States. This was published in 2016 and was based on data from the population in 2010. And even at that time, there was an estimated 1.5 million adults with congenital heart disease, with about 10% of them being considered severe, sort of the single ventricle transposition type complex patients. That at this point is likely well over 2 million and will continue to grow. So people often compare the number of adults with congenital heart disease coming into the cardiology practice, or they compare it to a tsunami. And it's kind of a tsunami of difficult patients, because a lot of them are lost to follow-up as soon as they quote unquote graduate out of the pediatric practice. And because of that, roughly 50% of them will either have heart failure or arrhythmias when they present back into a cardiology practice as an adult. Furthermore, there really aren't enough CHD cardiologists being trained at this point to manage this population. And part of that has to do with poor reimbursement, some lack of exposure in adult cardiology training. And in general, ACHD care is limited to larger academic centers if you want ACHD specialized care. And so many community cardiologists will get these patients and sometimes won't know exactly where to send them. Excuse me. The Adult Congenital Heart Association has done a reasonable job of creating accredited ACHD centers of excellence to help standardize care, but they have fairly extensive requirements, making it somewhat difficult to have a center of excellence, center of excellence. And because of that, there are only 51 centers in the United States, and that's only within 26 states, and they're frequently adjacent to large pediatric centers. And even when I was at UAB, we had a fairly busy ACHD practice and ACHD clinic with ACHD cardiologists, but we were missing a couple of pieces, and so we were never accredited when I was working there. If you look here, this is from the ACHA website. This is a list of everything that you need if you were to start a center of excellence. Clearly, you would need a cardiologist, usually more than one. You need advanced practice nurses or physician assistants, a registered nurse, surgeons, access to heart failure transplant and heart and potentially heart-lung transplantation, electrophysiology, catheterization services, and the list goes on and on here. I'm going to briefly talk about the surgical piece because that's what I do and what is required there. So the cardiac surgery requirements require that the surgical director either be certified by the American Board of Thoracic Surgery in congenital heart surgery or have some significant experience doing congenital heart surgery. And I think that The second stipulation was put in there for some of the older surgeons that started doing congenital heart surgery before there was certification. I think now moving forward, for the most part, all surgical directors for centers of excellence will need to be board certified in congenital heart surgery. There's also a minimum of 2 surgeons needed to run one of these programs. And part of that is just so that there's a guarantee that there's always 24-hour, 7-day-a-week availability for consultation or emergency surgery. There's a requirement for expertise in mechanical support and cardiac transplant, and then all surgical patients must be discussed in a multidisciplinary format. And I would say most ACHD programs do this, but it needs to include ACHD cardiologist, interventional cardiology, electrophysiology, imaging, anesthesia, and ICU. And I'll say at our multidisciplinary conference, there are usually about 30 people logged in, and we do this every week. Our program here in Seattle has 7 adult congenital heart disease cardiologists, 2 interventional cardiologists, one that, like me, works both at Children's and the university, 3 electrophysiologists, 3 heart failure transplant cardiologists from the larger group that tend to collaborate with us a little bit more frequently than the others, 1 dedicated anesthesiologist, a very large and busy cardiothoracic ICU, and then 2 surgeons. So getting to the surgeons, when you have an ACHD program, what is the ideal type of surgeon? And what I mean by that is, should a pediatric congenital surgeon be doing these operations, or should it be an adult surgeon? Because there are certain aspects of both practices that come into play when you are operating on adults with congenital heart disease. And the pediatric congenital surgeon, I would say, typically is not that interested in the adult population, primarily because they tend to do the training so that they can operate on children, do some of the more interesting repairs, such as arterial switch operation, like I've shown here, or the Norwood operation. And unfortunately, in the congenital community, I feel like operating on the adults is sort of considered a lesser surgery in general. But what about an adult surgeon with a congenital background? This is something that was fairly common when patients with congenital heart disease started surviving into adulthood. But a lot of times, as I'll show in some of the slides coming up, those cases were a little bit more straightforward: atrial septal defects, coarctations, ventricular septal defects. And the more complex patients were not surviving to adulthood quite yet. I would say at the more contemporary level, surgeons are a little less comfortable with this. They don't get as much congenital training as many of the older surgeons did in their training programs. There has been shown that the outcomes are less favorable when adult surgeons do some of these operations, and there's just more and more complexity as time goes on. So one of the only studies that really looked at this, at least in the United States, was published in 2008 by Tara Caramello, who's at the Cleveland Clinic now. And this was a nationwide study looking at the national inpatient sample, which is an administrative database, so it's not the most perfect clinical data, but they looked at operations done over a 15-year period from 1988 to 2003 and identified about 40,000 ACHD operations within the cohort. And then they compared, quote unquote, adult surgeons to pediatric surgeons. How they defined pediatric surgeons was a little bit strict in that a pediatric surgeon had to do at least 75% of their case volume as in children to qualify for that title, which is interesting because I consider myself a pediatric surgeon, but I probably only do about 60 to 65% of my total volume at the Children's Hospital. They look specifically at death as a major outcome, and then length of stay and cost. And if you look at the table I have here on the right, the mean age of the patients was about 50. I would say the mean age of most patients, at least in our group here, is a little bit lower, probably in the high 30s. And most of the operations were done on ostium secundum atrial septal defects, which is an operation that's largely gone away with transcatheter ASD closure. What they found was that if a non-pediatric heart surgeon did the operations in adult congenital patients, there was an odds ratio of 4.5 for mortality, and there was protective if a higher percentage of the adult patients were done by pediatric heart surgeons. So I would also like to mention that the surgical population has evolved over the last 30 years. And like the table I just showed in the past, this table on the right here is from a study out of the Netherlands, where they looked at about 20 years or 30 years, 20 years of ACHD operations that they had done at the center in Rotterdam. And again, there were a lot of septal defects that have largely gone away in the 2020s. And but they included a lot of their left heart lesions, specifically aortic stenosis at the valvar and subvalvar level, which is a large part of what we see today. But with the introduction of transcatheter devices for ASD closure, pulmonary valve replacement, aortic valve replacement, and coarctation stenting, a good number of these patients have completely gone away from the surgical practice. So looking at our data, this is about 200, a graph of about 225 cases that we've done since I've joined the group. And if you look at the large piece of the pie here is really aortic valve and aortic operations. That to me is really what the contemporary adult congenital population is. There are still pulmonary valve replacements that need to be done surgically or RV to PA conduits. And so that is still a large piece of it as well. But beyond that, it's kind of a smattering of different things, such as mitral valve repairs and replacements, mostly on patients with AV canal defects, tricuspid valve repair and replacement, occasionally with patients with Ebstein's. There are still some ASDs and VSDs that we do get to close, which are always nice cases. Occasional coronary anomalies, which I would say is slowly becoming a more common operation that we see. The double root operation is an operation for patients that have had the Ross procedure and need both an RV to PA conduit and aortic root replacement. And then a few transplant patients and pacemaker procedures. So the ACHD program at the University of Washington has a long history. Ed Verrier was the surgeon for about 30 years here and basically did almost all of the ACHD operations during his time. I came here in February of 2020, just before the pandemic, and Ed retired in March of 2020. That at the time when I was recruited here, I actually wasn't recruited to do adult congenital heart surgery. I was recruited simply to work at the Children's Hospital. And one of the younger cardiac surgeons at the University of Washington, Chris Burke, who has additional training in aortic surgery, was basically handed the ACHD program because nobody else wanted to do it. And he really had very little experience other than the fact that he trained here at the University of Washington. So he did a number of cases with Ed in his training. And while he was doing this, we were in the process of recruiting an ACHD surgeon. And that recruitment eventually didn't work out, mainly because of the pandemic. But it did start the partnership between Chris and I, and you know, serendipitously, this all came together in a very nice way. He did call me in March of 2020, my second month here, and when you have another surgeon that you don't know call you and ask you for help with the case, you know it's going to be really quite daunting. And so he called me up and said, "So I have this patient over here at the university, and he's fairly complex. I was hoping you could come over and give me a hand." It was a 26-year-old male who had a history of detransposition of the great arteries. He had undergone an arterial switch as a neonate. but it had a number of problems with his neo-aortic valve, requiring a total of 6 previous sternotomies. He had had 3 previous aortic root replacements with different sizes of aortic homographs, and he presented to the University of Washington with aortic endocarditis and severe aortic insufficiency, and was quite sick from all of this. So I came over and did my first operation at the University of Washington with Chris. And you can see I just sort of listed some of the aspects of the operation, and I'm going to go through them one at a time. So right axillary cannulation is something that any aortic surgeon is very familiar with. Many of the aortic arch operations they do start with right axillary cannulation so that they can do selective antegrade perfusion to the brain while they're working on the arch. We elected to do this as we knew that the reentry was going to be quite difficult, and we wanted to have stable arterial access from the get-go. We did a reduced sternotomy, got in without too much trouble. We had to take down the pulmonary arteries, or the LeCompte as we call it, when you pull the pulmonary arteries in front of the aorta at the time of the arterial switch. And that was really one of the main reasons he wanted my help, was because we had to take the pulmonary arteries out of the way so that we could actually get to the aortic root. Once we had done that, we did an aortic root replacement, but the coronaries were so frozen within the tissues around the aortic root that we had to do a Cabral reconstruction of the coronaries, which is something that with his expertise we were able to complete. And then I reconstructed the left pulmonary artery with a tube graft, and we had so much coagulopathy and bleeding afterwards. We had to do a temporary closure with a Cabral patch, which was something I'd never seen before, but it's essentially closing or taking a piece of bovine pericardium and sewing it over the front of the heart around the great vessels to basically contain all the bleeding and allow it to tamponade. He was brought back 2 days later when the Cabral patch was removed and he was closed, and he did fine. And then the two of us did many more procedures later that year. And once it became clear that they were not going to have a recruitment of an adult congenital cardiac surgeon, we decided to, develop the program with the two of us equally in charge, but with separate focuses. So getting back to this graph, if half the operations that an adult congenital within an adult congenital population are aortic valve or aortic, it definitely makes sense to have an aortic surgeon be your partner within an ACHD program. So the way specifically that we split it up is that any patient with congenital anatomy, physiology, excuse me, or right-sided lesions gets referred to me. Anybody who needs a transplant gets referred to me. And then anybody who has advanced aortic disease or potentially needs an aortic valve repair, replacement, or arch replacement gets referred to Chris. And anybody who needs a pacemaker, we kind of split those up. But I don't know that there are too many surgeons that have profound understanding of electrophysiology and pacemakers, and so I end up taking the majority of those. And this is sort of a repeat of what I just mentioned. And so I wanted to just give you a list of some of the cases that we do together, because while there are a number of cases we do on our own, the particularly complicated ones that involve both aortic and congenital issues, we have continued to do together to maintain the best outcomes. We've started a ROS program, and that's something I'm going to talk about here in a little bit, but every ROS procedure we do as a 2 attending case. Most aortic valve repairs we will do as 2 attending cases, double root replacements, and then any aortic root or ascending operation that's in combination with complex congenital anatomy, we do together. Any complex left ventricular outflow tract reconstruction like a cono, we tend to do together. And then unusual coronary anomalies we'll do together as well. mainly just in case we need to do a coronary artery bypass. It's good to have an adult surgeon that does this more frequently, working with you. So now I just want to go through a few cases to show you how the collaboration has really worked out. The first one being a 25-year-old male with double inlet left ventricle, L-transposed great vessels, and coarctation of the aorta that was initially palliated with a Norwood procedure, had a bidirectional Glenn and then an extracardiac Fontan. He had been followed in the ACHD group, or by the ACHD group, for an ascending aortic aneurysm that had now progressed to 7.1 centimeters, and he had developed severe neo-aortic insufficiency from his pulmonary valve, and was having intermittent chest pain and had a mild decrease in his LV function. So he was referred for surgical repair of his aneurysm and replacement of his neo-aortic valve. You can see his echo over there with this severe neo-aortic insufficiency. This is another operation. We proceeded with right axillary artery cannulation. We did a small left anterior thoracotomy to place an LV vent as well, given how much aortic insufficiency he had. We knew this was going to be a case where we were going to be cooling considerably. And in the event that he fibrillated, we wanted to make sure that the LV was vented. We cannulated his IVC essentially from the femoral vein and then directly cannulated the SVC within the chest. Cooled to 18 degrees, separated his native aortic root from his Damas K. Stanzel anastomosis, and then performed a zone 2 arch replacement with a branch graft as well as a Bentall to the neo-aortic root, and then reanastomosed his actual aortic root to the Bentall graft. He was in the hospital for a couple of weeks, mainly with chest tube output that was a little bit higher than normal, which you would expect in a Fontan patient, but ultimately went home and did well. Here's an MRA that we got in follow-up that shows his reconstruction. And you can see, I'm pointing right here to his native aortic root, which is a little bit smaller than his neo-aortic root with the mechanical valve, but it's sewn directly to the graft here. And whoops, and the graft goes all the way up into the arch and the aneurysm is completely gone. The second case was a 46-year-old patient with heterotaxy syndrome, situs inversus with mirror image dextrocardia, was born with total anomalous pulmonary venous return, double outlet right ventricle, and a partial canal defect. So all of this was repaired as a child. She had a revision of her ASD patch and tricuspid annuloplasty as a young adult, and then had progressively developed heart failure symptoms related to severe left ventricular outflow tract obstruction and aortic insufficiency. Her VSD patch from her double outlet right ventricle repair had significantly calcified and had given her a long, narrow left ventricular outflow tract. You can see on her echo image here, everything is extremely crowded underneath her aortic valve, and the gradient was extremely high. The CT image I put in there just to show you all the calcification underneath the aortic valve. So this was an operation we did with a reduced sternotomy, standard cannulation, standard cardioplegia. But after we resected the aortic valve leaflets, looked into the left ventricular outflow tract, we identified a couple of subaortic membranes, as well as significant calcification of the VSD patch, and ultimately decided to open the right ventricle where she had had a previous patch placed, completely cut out the VSD patch, and then use that opening to do a cono aortic valve replacement and enlarge her annulus. And we were able to get a 23 millimeter St. Jude mechanical valve in and really expand her left ventricular outflow tract. Here's an echo image from the operating room when we were done that shows a much larger left ventricular outflow tract with low velocity. She's done quite well. The last and third operation I wanted to just mention that we did, this was one we did this month actually. It was a 32-year-old female with Turner syndrome who had had 2 successful pregnancies, but at the end of her second pregnancy, she started having chest pain. And on workup for this had pretty significant ST changes on an exercise treadmill test that was localized mainly to the left side of the heart. She had a CT scan that showed that she had an intraseptal left main coronary artery that came off the right coronary sinus, but did have a normal ostium and appeared to just have a myocardial bridge from the intraseptal course. So she was referred for surgery, and just wanted to show her cath image because it's a little bit hard to see on the CT, but the aortic root injection you can see is in the right coronary sinus, and you can see the right coronary filling there, but the left main comes off right next to it. There's a huge vessel, runs right through the septum, and then bifurcates into the LAD, which you can see running down right here, and a very large dominant circumflex. She did have FFR done during this cath and at rest did not have any significant compression. And even with dobutamine stress, she didn't have significant changes, but given her ST changes with exercise, we felt that surgery was the right way to proceed. So we plan to do transconal unroofing as described by Hani Najim from the Cleveland Clinic. And this is an operation where you essentially divide the right ventricle completely just below the aortic valve, and then use a knife or scissors to completely unroof the left main coronary all the way from the aortic root to where it bifurcates underneath within the septum. And I have a few pictures from this operation. And this, you can see right here, I'm pointing to the pulmonary valve, and this is the main body of the right ventricle after we've divided the right ventricle. And from the aortic root, I can trace along the left main coronary artery here as it bifurcates. And you can see it is a large vessel, and we completely separated it from the muscle. We used a patch of her autologous pericardium to reconstruct and put the two ends of the right ventricle back together without compressing the vessel. And this is what it looked like when we were all done. The right ventricle comes together primarily in the front, but with the patch kind of on either side. She did well, went home after about 3 or 4 days in the hospital, and I haven't seen her in follow-up yet. The end of my talk, I really want to talk about the way that we manage young patients with aortic valve disease and some of the issues that come up. It's very common in the ACHD population for patients who have been followed as children for bicuspid or unicuspid aortic valve to need something done in their 3rd or 4th decade of life. Many of these patients have a reluctance to take Coumadin for family planning issues or an active lifestyle. And a lot of them come in hoping to get something like a TAVR or a tissue valve. But we've taken so many of those out in this population that we've really tried to steer away from it. Interestingly, throughout the nation, there are more and more tissue valves getting put in the younger patient population. And this is a graph from a paper that was published by Goldstone and others from using data from California. It was in the New England Journal of Medicine. And this graph I find interesting because if you look from 1995 to the mid-2000 teens, the percentage of tissue valves that have gone into patient, which is shown as red, has really increased over this time period, likely due to the promise of valve-in-valve TAVR. Looking at the survival curves for these patients, there is a slight advantage to a mechanical valve in the younger patient. But really, I think the most striking thing about these graphs is that there's a 30 to 40% mortality in the 45 to 55 cohort and 55 to 65 cohort at 15 years, which is fairly significant. Similar data came out of Canada. This was a study out of Montreal that looked at 469 isolated mechanical AVR patients less than 65 years old. And these were all elective cases. They excluded anybody that got a concomitant procedure, anybody who had coronary disease, any re-op, emergency, or active endocarditis. So these were kind of as run-of-the-mill mechanical AVR patients as you could get. The mean age was in the low 50s, similar to the previous paper. And they found at 10 years, the survival was only 87%, which is compared to 94 for the age-matched controls. Now, that's not that bad. But if you look at survival free from reoperation, in addition to that, about 1 in 5 of these patients was either dead or had to have an operation at 10 years after having a mechanical AVR. And these are as straightforward a patients as you can get. We looked at our own data at the University of Washington after mechanical AVR, and these were all comers that got a mechanical AVR. So some of them were quite sick at the time of the operation. But there was a 29% mortality at 15 years in our data, and a 50% either dead or major event rate at 15 years. And you can see the major events listed over there, mainly significant bleeding or embolism related to taking Coumadin. So there is a significant cost in patients that are young patients that get aortic valve replacement. And there have been a number of studies like the ones I've shown that young and middle-aged patients definitely pay a price in life years or complications, regardless of what valve type we put in. And so we thought, is there any way we can do better here? And so we've really focused on trying to maintain what we call the living aortic valve complex in our patients. And what does that mean? So that means either aortic valve repair or the Ross procedure. And so the reasons we do this, most of these patients will have better hemodynamics. They're more resistant to infection. They don't need anticoagulation. And there are some data to suggest that there is improved survival with these techniques. This is a figure out of a paper that was published in JACC a few years ago, looking at the Ross procedure and the benefit in life years gained by young patients. And the reason I put this up here is because the data hold true depending in several different countries. The upper left-hand corner is Montreal. This is another Canadian study in figure B. Figure C is an Australian study, and then figure D, mostly looking at life years gained, was from Great Britain. And really, the take-home point is that the Ross is the only aortic valve substitute that has been shown to restore patients to near normal life expectancy. And so with this in mind, Chris and I started the University of Washington Ross program, doing our first case in June of 2020. And we've done a total of 90 patients to date. Now, these are not all adult congenital patients. And when I say adult congenital patients, I mean they weren't all referred from our ACHD group. About 30 of them have been referred from our ACHD group. But like any program that has some success, we've started to get referrals from other groups around the Northwest, and it's really kind of taken off. We have excellent clinical and valve outcomes, have about a 1% mortality, 1% stroke rate, and a 98% freedom from moderate aortic insufficiency. Oops. We do take a very tailored approach to the way that we support the autograft, because everybody in this room who has ever heard of a Ross knows that the Achilles heel of the procedure is the fact that the autograft can dilate, and the patients need operations later on down the road. But with different ways of supporting the autograft, there have been more and more contemporary data to suggest that the autografts will last longer. So every patient that we operate on, and I apologize for the picture here, but we're having a professional artist put this together now. It just isn't quite done. But every patient gets a Dacron ring at the sinotubular junction between either the aorta or a graft if we're also replacing the ascending aorta. And we call this the naked technique. This is what we use for patients that have aortic stenosis predominant disease. And the reason we don't do anything at the level of the annulus is that patients with aortic stenosis tend not to develop annular dilation after the Ross procedure. That tends to be more in patients with significant aortic insufficiency. We also do our autograft implantation with interrupted sutures. And we feel that that helps us maintain the geometry best and gives us the best valve outcomes. In patients with aortic insufficiency predominantly, or an annulus greater than 27 millimeters or more than 2 millimeters greater than the pulmonary annulus, we do a double ring technique where we support the aortic annulus in addition to the sinotubular junction with a Dacron ring. And we create these rings simply by cutting a small piece off of a Dacron graft and sewing them to the appropriate location. A couple of times we've done what Chris calls the shawl, which is essentially a fully supported Ross within a Dacron graft that has been opened to create keyhole flaps for the coronaries. But this we really only save for patients that have extremely dilated roots. And we often are not doing Rosses on these patients in general because of the data to suggest that they have a poorer long-term outcome. If you look at the outcomes of our program, this is a paper that we're in the process of publishing, or this is a figure from a paper that we're in the process of publishing that has our first 71 patients. We have a very low short-term complication rate. I would say early on, we did have a few pacemakers or heart block afterwards. This has really gone away, I would say, and this was predominantly in patients that were having aortic valve prostheses removed and then a Ross procedure done. And so there was a little more dissection done around the aortic annulus that led to some heart block. But other than that, our complication rate has been low. As I mentioned, our mortality rate has been very low, and we have about a 5.6% reintervention rate at this point. We had one take back for bleeding, one patient who developed a pseudoaneurysm at the anastomosis between the autograft and the aorta at 6 months that had to be reoperated on. And then, interestingly, we've had, it seems, more problems with our homografts than our aortic valves. And a couple of them have had to have balloon dilations at this point. And since this paper was written, we've had one more that had to have a melody valve placed in it. So we have learned some lessons doing these procedures. One of the lessons is that it's kind of a delicate balance between rapid programmatic growth and optimal outcomes. We've been lucky in that Chris and I have been able to do most of these operations together, and there's one other aortic surgeon at the university that will assist Chris as well. And so having a dedicated and specialized team, we feel is essential, particularly our goal was to do this for the first 100 to 150 cases, and we're just coming up on 100 cases here probably in the next few months. I do think that this is an operation where the patients do benefit from a congenital and aortic partnership, or at least they did early on, because I certainly had more familiarity with pulmonary homografts than Chris did early on. And so there was a lot that he gained from my assistance. And I do think that it's really good having two experienced surgeons looking at the aortic root when you're implanting these autografts to make sure that you really get the optimal geometry. It's also important to really have buy-in from everybody involved, including the ICU and our outpatient nurses and nurse practitioners, because it's been shown, and we feel very strongly about that good blood pressure control after this operation can help prevent autograft dilation from occurring. A lot of that does occur in the first 6 months, and so we're very strict about keeping our patients' blood pressures at 110 or lower. And many of them do go home on 2 or 3 antihypertensive medications that we're usually able to slowly wean off over time. And then follow-up is key in this population. We need to know what's happening with these valves, what's happening with the homografts. And as long as we're able to do that, we feel that this is a really good option for our young patients. I'm going to switch gears a little bit here and move to aortic valve repair. And I'll first state that I'm certainly no expert in aortic valve repair, but I've learned a lot working with Chris over the last 2.5 years in our partnership. This is something that's reserved primarily for patients with primary aortic insufficiency, and that's commonly associated with aortic root aneurysms. Most of these patients will get a reimplantation style valve sparing aortic root replacement at the time of the aortic valve repair, simply to support the annulus and sinotubular junction. And most bicuspid aortic valve aortic insufficiency patients can be repaired. And we've seen quite a bit of success of that, especially in the last 2 years. This is a rapid area of growth within the aortic surgery world and also within the congenital surgery world, although the repair techniques are quite different, I would say, between the two groups. Most of the aortic insufficiency in patients that we repair comes from pathology either within the annulus, sinotubular junction, or the leaflets, or in some cases, all three. And so you really need to address all three of those things when you're doing an aortic valve repair. So annuloplasty is important, at least the sinotubular junction ring if you're not doing a valve sparing aortic root replacement, and then leaflet repair and plication. One case I was just going to show you, this is a repair that we did in a patient with bicuspid aortic valve. You can see that both leaflets had to be plicated. This is a good example of a reimplantation style valve sparing aortic root replacement. And with the right geometry, you can really get a nice result. You can see those leaflets, and he puts the sucker or the forceps in there. The leaflets come right back together. This patient had left the hospital with no aortic insufficiency and a mean gradient of 7 through the aortic valve, which is quite excellent. Similarly, you can repair patients with trileaflet disease, and you may say, well, how is this congenital heart disease? It isn't necessarily, but there are occasionally patients with congenital heart defects that do come in with a trileaflet aortic valve that leaks. And this is a patient that had moderate aortic insufficiency with a root aneurysm, had a history of some bleeding issues and did not want to take Coumadin, and did have tricuspid aortic valve with an eccentric AI jet, which is generally a red flag when you're doing aortic valve repair because the trileaflet valves are actually harder to repair. But occasionally, if you have prolapse of one of the leaflets, even in a trileaflet valve, you can get a fairly good repair. And this patient got a reimplantation valve sparing root replacement with a commissural reimplantation and plication of the right coronary leaflet. And you can see here in his echo at the end of the operation, essentially no aortic insufficiency or stenosis. And so this can be achieved in patients with trileaflet valves as well. And I will say a case that we recently did on a patient that had a Ross procedure, we did a similar repair and got a really nice result. So even in patients with failed Rosses, you can do some of these repair techniques and allow them to keep their own valve. So just wanted to show what complex aortic cases within our ACHD program looked like if you broke them down. This is 75 patients over about the same 2.5-year period. You can see we do have a large number of Rosses, 28 of them. 20 of them have had ascending aortic replacement or arch replacement. Small number that have complicated LVOT or subaortic reconstructions. Just had one TVAR in this group. Good number of Bentals, either mechanical or biologic. About 20 aortic valve repairs with reimplantation, valve sparing aortic root replacement, and then 5 double root replacements for patients that have had the Ross procedure in the past. So to conclude the talk, I just wanted to give a few final thoughts about the surgery in the ACHD population. it is a population that is going to continue to grow and will continue to need surgeons to take care of the patients. One thing that we didn't really talk about was, well, how do you train someone to do ACHD surgery? And if you don't have the luxury of having a pediatric congenital surgeon and an aortic surgeon to run a program, there has been some thought about training people specifically to do ACHD surgery. There aren't any training programs at the moment, but if there were to be one, I think it would need to involve, at least a year of congenital training and at least 6 months of advanced aortic training. It would probably need some heart failure transplant training in there and structural heart disease training. So those of us that do adult congenital heart disease surgery have talked about this as a possibility. And it wouldn't be surprising to me if in the future we had specific fellowships for patients or for trainees that were interested in doing adult congenital heart disease surgery. Surgery on the aortic valve or ascending aorta is very common in this population, and it's probably the most common thing that we see these days. It used to be pulmonary valves and ASDs, no longer. The expertise of a surgeon familiar with complex aortic techniques is critical for the success of an ACHD program, and this partnership between a congenital surgeon and aortic surgeon definitely offers the most comprehensive care for this complex population. And with that, I would like to thank you for inviting me out to give this talk. And I'm happy to answer any questions. Would love to have anybody's thoughts about anything I've talked about today. Thank you.
Anyone have any questions? Thank you, Dr. Mauchley.
I do.
Should I grab the microphone?
We've got the audience mics on,
Oh,
so
so
whatever you want to do.
Yeah, so thank you so much. This was an incredible lecture. So thank you so much for doing it for us. I have a question about specifically heart transplantation in this patient population. What would you say are the challenges? Like, would you say, so we have a solid transplant and VAD program here, obviously adults. What are the challenges to transplant those patients? And how do you guys do it? Do you believe that you need to have a adult congenital or congenital surgeon present for those procedures? And what are the challenges like in the immediate perioperative period?
Yeah, that's a great question. I could give an entire hour-long talk about that specifically as well. Just to give you some historical context here, ACHD transplants were done here before I came. They kind of closed the program due to poor outcomes. The surgeons from Seattle Children's had no involvement whatsoever in the program before I came here. And this was a question that I had to answer when I was in Birmingham as well. And the way that we did it in Birmingham, where I think it works, and the way we do it here now, is that all congenital patients that are being worked up for transplant need to see a congenital surgeon, which in this case is me, and an adult transplant surgeon as part of the workup. And then after they've been selected for transplant, when they come to transplant, we do the cases together, similar to how Chris and I do with some of these complicated other ACHD cases. So I act as the primary surgeon specifically for patients with Fontans. That seems to be the group that's going to be growing the most in the transplant world. And then one of the adult heart failure attendings assists on the operation. And because I'm not as available, because I primarily work at the Children's Hospital, that surgeon becomes the primary attending for the patient postoperatively, and they include me in decision making as needed. But once you've done the transplant, for the most part, they become a transplant patient, with the exception of some of these patients will have some liver failure. They may have more chest tube output than you're used to. If they have AP collaterals, they may have more loading of the left ventricle than your standard transplant patient. One way that we've gotten around a lot of those issues is, so far at least, any Fontan patient that we're going to transplant at the University of Washington gets admitted while they wait for a heart. they get optimized in terms of their volume status with diuretics, and they get taken to the cath lab and have every AP collateral coiled that can be coiled. So that puts them in the best situation going into the transplant from a physiologic standpoint. And so far, we've had pretty good success with that practice.
Any other questions?
Could you just comment a little further on Ross procedure patients, or what age demographic do you consider ideal for that? And I'm just curious because of the number you've done. And,
Yeah. No, that's a good point. And I will say that Chris and I kind of have different opinions about this. I think that the Ross procedure is a great operation for any child and anybody up to the age of 40. And then once you get beyond 40, it gets a little bit, there's a bit of a gray area. And I think if you're doing a Ross in somebody over than 60, you really need to be think about what you're doing, because it is a complicated operation. It's a longer operation. I don't think that you get the same potential life year benefit once you get certainly over 60, but even when you get above the age of 50, I think it's certainly a gray area. But really, it's the best operation, I would say, for a young woman, certainly anybody interested in having children. And then anybody who's relatively active up to the age of 40, I don't think twice about a Ross. And then after the age of 40, we certainly have a discussion about all the options and, what the reintervention rate could look like after a Ross compared to other procedures.
thank you.
You're welcome.
There's one virtual.
But,
question.
sorry, one more thing on that. I will say our Ross cohort has included many patients in their 50s and some in their 60s because of referrals that have gone to Chris's clinic. And I'm involved if he wants me to be on those cases, and I support anything that he does, but those are not coming from the ACHD group. And so I tend to be less involved in those cases.
All right, well, we do have one virtual question. Dr. Mauchley, thank you so much for that excellent overview. We really appreciate your time and expertise. The question comes from Dr. Vinny Bapat, and he asks Ross, or this is more of a comment essentially, but Ross outcomes versus conventional AVR are never compared in same age group and hence mismatch age in long-term survival. Need better data, including that of homograft reinterventions to offer this in older patients greater than 60 years old. I don't know if you have any comments to that, Dr. Mauchley, but that was a Q&A pod.
Sure. Let me see if I can. Yeah, I mean, I agree. I think that what has really led to the resurgence of Ross, I would say, in this last 5 to 10 years has been some of the long-term survival data from larger centers that did them through the 90s and into the 2000s. It's true that there hasn't been a great comparison between the two types of operations, particularly in a randomized fashion. The only randomized trial that I know of that includes the Ross was between a Ross and an aortic homograft placement. It was done by Magdi Yacoub a number of years ago, and that showed a improved survival in patients that got a Ross over an aortic homograft, but that's not a very useful comparison, I would say. Every other study has been retrospective in nature, propensity matching, et cetera, and so the data aren't perfect. For me, like I said, I find that this is an operation better for younger patients. And I do think that the hemodynamics that you get with a Ross do benefit them in terms of their left ventricular mechanics and then just the number of years that they go without any significant hemodynamic compromise at the level of the aortic valve. But it's not a perfect operation. I'm not trying to suggest that. There really is no perfect aortic valve substitute for a young patient. So I understand the concern for sure.
Thank you. Other questions? Thank you very
Well,
much.
thank you very much.